Thank you, sir. Thank you so much. Wonderful. Tamil Nadu has done wonderful in e-health. Let me tell you, because we are observing from the center various states. You have done a wonderful job. Thank you very much.
I would like to invite Thalcare, Rajat, Agarwal to come. And please, if you want to take seats, please come. People who are standing behind, if you want to take seats, there are seats here. We'd like to see your faces. Come.
Good afternoon, ladies and gentlemen. Thanks a lot, Manthan, for giving us this opportunity to share. So July 2011, 4 people walk into a government institute, a super speciality government institute, government of Karnataka, based in Bangalore, into a ward meant for some children who have a disease called thalassemia. Now, for those of you who don't know thalassemia, these are children who never produce good red blood cells. They depend on blood transfusion for a lifetime. Data number 1, WHO tells us there are 60,000 kids in our country who have thalassemia. Data point number 2, 12,000 kids with thalassemia are born every year. Data point number 3, 90% of them die before the age of 10. Data point number 4, if the same kid was born in the developed nations, he'll have children, he'll die of old age. Thalassemia is not a disease, it's a disorder. So when these 4 people walked into this government hospital, what they realized is there are these lean children who absolutely thin, you can't tell their age, who are there being treated. What they are being given is blood transfusion alone. They come to the hospital every 20 days, get a blood transfusion and go out. Stats tell us they are not going to be there for too long. Something was wrong. That's where this tool was developed. Thalcare, an application for complete end-to-end management of thalassemia. So what is Thalcare? Thalcare is a web-based application designed for systematic disease management particular to thalassemia. What does it do? If you go to a hospital once, just once, you come back with 15 records, right? If you are going to the hospital right from the age of 6 months till the time you are alive, every 20 days, you are coming up with a vast amount of medical data. Do you think anywhere in the country our government hospital doctors have the bandwidth, have the time to look at all that data, figure out what is the current disease status of the patient? WHO protocols are pretty clear. Thalassemia International Foundation guidelines are not clear on what is to be done. That is why survival is there in the developed world. In India, the problem was you are getting this data in pieces. How do you make it available in a manner that the clinician, the treating doctor, can come up with sensible decisions? So what did this tool do? We put in one single data entry operator. Salary was 8,000 at that time. And what the person was told is, this is a government institution. Nobody else will put in the data for you. You just take all these paper records and key them into the system. So the morning the child comes to the center, they do a simple complete blood count, put in the data into the system. So is the system only managing data? No, that's where the magic begins. The system is programmed to implement WHO and Thalassemia International Foundation protocols. It takes the history of the patient, the complication history, the recent medical records, the current evaluation, and generates a tentative treatment plan for the day. It tells these medical tests are to be repeated today. It tells this is the volume of blood to be transfused. It warns if the child has a complication because of which the nursing staff has to take adequate care. It is a system-generated automatic plan for management of the disease. How much time does it take? 20 seconds after you post the data. And then what happens? The child goes to the doctor, here's the slip. The doctor looks at it, obviously confirms. But now he's not looking at those thick files of data. He has the information presented in a manner that he can take correct, accurate decisions. The nursing staff is doing their job well. Throughout the day, the child is going around the center. Keynotes are being captured into the system. And in the evening, they are being keyed into the system. Once the child goes back home, they are being put into the system. End-to-end management of a chronic disorder, which was killing children. So we used all these technology, all web-based technology for this. So what is the biggest in a government setup? In a government setup, when you are working from outside, you know what was one of the finest thing that happened? For the first time ever in the history of the hospital, every Monday morning, the administrator was getting an email They didn't even have to log into a system, saying last week so many patients came. One of the patients actually went out of your hospital with an hemoglobin of 8 when the guidelines wanted to be 14. It told them how many children have HIV positive in your hospital who are attending this clinic. How many of them are on ART, how many of them are not. For the first time, the administrator got to know without asking anybody how many exactly, what percentage of blood units are coming from outside. If they are coming from outside, at what price? So the system administrators, the administrators of the hospital automatically got informed on the problems that are happening in the unit, and so corrective action came about very, very swiftly. Coming to uniqueness and impact, I'll tell you something very interesting about this application. I understand not every thalassemia children can afford a phone, but if they have a 2,000 rupee phone, they get their entire disease information on the mobile. They get a user account, they get a password. Why is this required? Thalassemia is not managed everywhere. If a person is coming from Meerut to Delhi, he has fever in Meerut after going back home, the local doctor needs to see what was his disease status. Without that, he can't prescribe things to him. So we've made all the data available on the mobile phone, not just for the patient, but also for the clinician, also for the administrator. Internet-enabled devices, any device, anywhere, it works. Whatever standards we have used are TIF standards. So far, we have taken the center. When the system was inaugurated, 65 patients were coming. 300 plus children are coming in a public hospital every month for systematic care and management. For the first time, they are coming up with publications indicating real strategies on improving thalassemia as well. So it enables prevention and care. See, thalassemia is a genetic disease. It runs in families. If you want to stop thalassemia, the only way is to screen the families in a cascade model. The cost-effective way is screen the families in a cascade model. The system enabled that. Let's look at that. 5 children, first antenatal screening was organized for 6 mothers, and 4 children with thalassemia, 4 births with thalassemia were averted. Right? Lifelong suffering was averted. 15 families were identified for bone marrow transplantation. Nobody looks at bone marrow transplantation when they come everyday basis, but the system helped them identify and prepare the kids. The first transplant is likely to happen in January. As a result of better treatment, children are showing improvement. There is better hope for 300. So once we had these results, what did we do with it? In July this year, this was installed in the second organization in Bangalore. The scaling up cost was 0. And as of date, they have got 71 more children enrolled. Now, we plan to extend it to 20 centers across the country in the next phase. We want a center enabled with Thalcare every 200 to 250 kilometers, at least from any corner of the country. We plan to reach out to 5,000 kids in this phase. Prove this at a level that has never been seen. Give evidence, scientific evidence that this is the right way ahead. So, sure. Okay, so I'll just conclude by, I'll give the last word on this. It's a pretty simple thing. I showed you the entire tool. Let me just talk about the cost of development, deployment, management, and all of it. This entire tool costed the organization which actually implemented it in phase 1. First year of implementation, 6 lakh rupees. Second year of implementation, 3 lakh rupees. Public healthcare setup. And the performance, I can show the survival charts to anybody who's interested. I can show the growth charts, hemoglobin increase charts. It's better than any corporate institution in the country. That's what we want to do for the entire nation. Thank you.
Questions? Yes.
Have you linked up with any blood bank?
There are 3, nice question. There are 3 blood banks which are linked, 3 and no more, because you have to give specifically prepared blood components to thalassemiacs. All across the country, they give any component, but because of the regulations, only saline washed PRBC is given as the regular component. Whenever there is a complication, filters are attached. So yes, it is linked with the blood banks. It is also linked with the donors for rare groups. If a child with AB negative is there, you immediately know that these 6 people have volunteered to donate for him. So before the child comes, the unit is already prepared and kept in the blood bank. Any more questions?
Sir, is this on an open source? Can this be integrated into our database so that we have data?
Fantastic question. This is being integrated with the hospital management system, which is being deployed in Government of Karnataka. We have open connectors to any and every technology. Like I told you, there's already an app in the App Store which is working on it. So it's a very open platform. As long as the security is taken care of, we can work out integrations with anything. Anything else?
Probably just one part of it. Just wanted to know who creates the account of the user, because you said that once they have the application, so they can just log in with their user details. But who creates it and how complicated is the registration process?
See, the center manager is the person who creates all these accounts.
Your center manager?
No, in every center, wherever this tool is deployed, there's a center manager. And that person need not be extremely well trained and qualified. They need to know how to use the system. Training takes about 2 days of time. Now, the first day the child comes is a long process because his entire family history is taken. How many cousins do you have? Have the cousins been screened for thalassemia or not? What can we do to reach out to them? How many times did you take transfusion? Where did you take transfusion? So the first day is a complicated day. It takes about 1 hour of time to enroll a single patient. But once that's done, you have everything about that patient, financial background, affordability, all of it on the system itself.
To get the answer, you have to understand the disease thalassemia. So it is thalassemia major, thalassemia minor. It is a genetic disease. How it's transmitted with parents and all those, that's antenatal screening he mentioned about. So there are so many factors we have to know more about it, but it is something incredible work they have done. I'm very happy to know about it. Thank you. Anybody wanted to have a question? Yeah, quick.
You told that it's a decision support system, right? For that type of application, you need to, the data is in a parameter manner. Your application is actually, all data is captured through a parameter manner, or you are converting the data into a parameter format.
See, both kind of things are happening. I'll give you the simple example of how BMT eligibility is being calculated. Something where there is data and there is information. Every time you enter the liver size and the spleen size of the child, that's the trigger to compute all this huge amount of information and take a decision on bone marrow transplant status. But once this status is updated, once it has been converted into an intermediate state of information available at the system, it will never be recomputed till the time there is a change in the affecting parameters.
Sometimes it may be computed because sometimes the data, blood levels may be changed or lot of.
Precisely. So for every decision, there are parameters which can affect that decision. Anytime you touch any of those parameters, there is recomputation. But interim storage makes sure that huge amount of information is available to you at lightning speed.
Thank you very much, Rajat. Yeah.
I think we have done a wonderful job. In case you have to scale up to the whole country, how do you plan to do it?
17th and 18th, we have a meeting with Thalassemia International Federation. We've already got awarded by Novartis as the innovative tool for the world. We don't want to create it in a kind of a manner that people can't get access to it. So our basic line is very simple. We need infrastructure to be able to train and deploy this across the nation. If one of the larger organizations is able to fund it, we'll make it available for it.
Sir, health is a state subject. To scale it up all over the country, individual states have to take it up. At national level, I recommend we make policy guidelines, but it is ultimately state to implement. So scaling it up all over country, your question is to get the states know about it, and states have to be in e-health mode to scale it up. It will take little time, but future is there. Sure.
So just if I can add, the interesting thing about this is when Indira Gandhi Institute adopted it, like I said, it had nothing related to digitization. We placed the first computer there, but we put in a person who was getting 8,000 rupees salary, and there were easy templates created to take care of all the data parameters.
It is for the local center.
For individual centers, it can be
It
scaled
can
up
be
on the choice
but
basis.
the country his question was, so that takes different kind of working model. We are working on that. Then everything can be incorporated into that. I'll tell that in the last. Yeah, next. Let us go with the next presentation. Thank you, Rajat.
Thank you so much.